Okay, I'm going to share with you, let me just give you a little quick background and maybe just a little bit of help with the things you just heard. So Dr. Koshiel talked about the different characteristics of the different kinds of cholangiocarcinoma. We have a terminology sheet that you can take a look at that will help you. We realize this is called about 30 different things. It's one of the tricky parts of figuring out for the patients what they have and what they need to do. So there's a terminology chart that you can get, and they'll be on the tables in the back, but you can get those terminology charts. It'll help you kind of map out and see when they're talking about biliary tract cancer, what that means and doesn't mean, and right? So that will help you. I'm going to talk with you about one of our major initiatives this year, which is Mutations Matter. Soon after, is my presentation up? Sorry. Oh, there it is. Okay. So soon after this meeting last year, we received a request for a proposal from Bayer Pharmaceuticals. They do every year a program called the Advocacy Think Tank. They call it the Shark Tank, and it's set up just like that. And they asked 30 nonprofits to send them a proposal for an innovative way to educate patients about one of 3 areas. One was in childhood cancer, one was in cancer survivorship, and one was in genomic profiling. So before I start, just for clarity, there's a difference between genetic and genomic. And genetic is familial, right? It's the genes that are passed from father to son, right? Genomic are the specific characteristics found in your tumors inside your body, and that's what we're talking about. When we're talking about molecular profiling, we're talking about genomic profiling. That's the specific characteristics of your tumor. So this has been a push for the foundation for a long time, many years. If you've been on the website at all, you know that we suggest strongly that every patient have genomic profiling, molecular profiling. Okay. So, I'm not going to go over these slides. You've already seen these. It's a global problem. Okay, I'm just going to give you a couple of facts that are important for you to know. Now, this is a general number. This does not have specifically to do with cholangiocarcinoma patients, but I guess I'm just going to look down here. Okay, is that 85% of adult cancer patients are seen outside of a major cancer center. So this is another major issue for rare cancers. So if you look there at a major cancer center, you're going to be seen by a multidisciplinary team. What does that mean? That means that you're going to be seen by an oncologist, by a surgeon, by an interventional radiologist, by a rad-onc, by a hepatologist, right? That group of people are going to come together. They're going to take a look. It's called sometimes a tumor board. They're going to take a look at your situation, and they're going to decide together what is the best way for you to move forward in your treatment. Okay. NGS is just another word for molecular profiling, is usually standard. In the U.S., at a major cancer center, you're going to be profiled. And then they're going to take a biopsy from your tumors. They're going to look at that profiling, and they're going to see what mutations you have. And then at a major cancer center, and sometimes in the community centers, these happen too, but you're going to have access to more clinical trials. And that's what we want for you. We want you to have every option on the table for you to decide with your team. So in a community oncology setting, you may wonder how we know this, and we know this because of surveys that we've done. So we know this from the patients, and we know this from providers. Usually you're going to see a general oncologist. They're good to send you to a surgeon if they think you're a surgical candidate. NGS is limited, and sometimes, and oftentimes we find that it's discouraged, that they will put a patient on a standard of care first, and once there's progression, or right, that's a your first line treatment. If there's progression on that, meaning your disease continues to progress, then they will say, well, then we'll get the profiling. The problem for us, and that we see with many patients, is the profiling needs to be done immediately when you're diagnosed so that you can plan while you're in a non-progressive state, having GEM-CIS or whatever the standard is that you are given, that you can plan when this progresses, what do I want to do next? And you can't usually do that unless you have that data in front of you and you're making a plan with your doctor. And sometimes in a community setting, then you see that there's limited or no access to clinical trials. And this this is a standard of care for cholangiocarcinoma patients, clinical trials. Okay, so last year, well, a year and a half ago, last year, pembrolizumab came out. And our patients, a small percentage, 3%-ish probably, have something called MSI high or a mismatch repair. And you can only find that out through getting your molecular profiling done, through getting this testing done. Well, when they made an announcement, there was an FDA approval for solid tumors that have this mutation or this mismatch repair. And we wanted to find out if our patients knew if they had that designation on that profiling. So we did a survey. It was 132 patients. This was within 48 hours. And this is when we were gathering data to make this proposal to bear. And this is what we found. So 52% of you had not had genetic profiling, and 48% said yes. That was shocking to us. We could not, that was really low. So we were very surprised by that. And so the next question that we asked was, why didn't you have genetic profiling? And 61% of you said you didn't know about it. Now, that was even more shocking because these are patients who are working with us, right? You're getting our emails, you're getting our newsletters, you're on the website, you're in the discussion boards, there's social media, and so we really had to take a look and decide what the message is not getting across, or there's some other reason that we didn't ask. So, of the 48% that did have molecular profiling, 62% of those patients said that the results of that testing influenced their treatment decisions. It's a lot. Okay, so this is Dr. Bardisi. At least 50% of cholangiocarcinoma patients have mutations that currently available treatments could potentially target. So this is a list right here from Foundation Medicine, provided us with this list. And these are the not all of these are actionable, but these are all mutations. These are the most common mutations that cholangiocarcinoma patients have. There are many mutations. This cholangiocarcinoma is the most highly targetable cancer in the GI cancers. So we have more mutations than any other cancer in the GI cancers. This is the good news. So actionable mutations means clinical trial options. So here's another statistic for you. This is a general statistic, not specific to our population, but general. Only 5% of adult cancer patients participate in a clinical trial. Well, why is that a problem for you? Because in a rare cancer, that means that's tricky. When my brother was diagnosed in 2005, we looked for clinical trials. There were 4 clinical trials that he could have participated in, but all had been canceled because they couldn't accrue numbers. Okay, so the way that and there's another, the reasons are there, right? Slow clinical trial accrual equals slow progress. It reduces interest of pharma and academia. If they can't accrue, they won't invest in this cancer, in more research. They just can't. And it limits options to increase your quality of life and life expectancy, and those are key issues for us. This is Melinda Bikini with her 6 kids. And this comes from the NCI Guidebook for Clinical Trials. The more people that participate in clinical trials, the faster we can answer the critical research questions that will lead us to better treatment options. Okay, Matt, I don't know if you knew I was going to use Matt here, but this is Matt. And here's Matt's diagnosis in 2003. He's profiled in February of 2015. You can see his mutations. I'm going to let Matt, can you click the audio so this will play? I'm going to let Matt tell, it's just a small clip. He's going to tell you about his story. It's right under his picture.
I had tried chemo, surgery, radiation and chemo. None of those worked. My cancer marker was at an all-time high. And back when I had my first resection, I had a tissue sample sent off for genetic testing. And I got those results back and kind of tucked them away. I didn't have a use for them. The last mutation on the report was something called MLH1. It had no actionable drugs or trials or anything. But fortunately, my local oncologist, he had just seen a study published in the New England Journal of Medicine that had to do with pembrolizumab. So he kind of put two and two together. MLH1 is a mismatch repair deficit-related genetic mutation, and the study had to do with people with cancer and mismatch repair deficit. So he could prescribe it off-label, but insurance won't pay for it. Unfortunately enough, I could afford that, so I said, yep, let's do it. So I started taking Keytruda every 3 weeks in October of 2015. My cancer marker started coming down dramatically, and by March of 2016, it was back to normal. I'm not shy about it, but I consider myself cured.
Where's Matt? Want to stand up, Matt? There's Matt. Okay. Now, if you couldn't hear clearly, he had his profiling done two years before this treatment became available. Your profiling is really, really important. You're going to hear about 2 additional trials that are going on that have happened since this. So 2 more targets that are available if you have that mutation. Okay.
I tried chemo.
Sorry. Next. Kate. So Kate is here as well. And Kate serves on our nursing advisory board, and she's an amazing research advocate. But Kate had the same experience. Kate has the CDKN2AB, I think it's called a loss. And she is currently, right, this was done in April of 2016, but there was no trial. On the bottom, you can see her current trial. There was no trial to target this mutation. This is a brand new phase 1. She's doing well, and she's here with us. Is Kate here? Where's Kate? There's Miss Kate, right back there. Okay? Yay. Okay, so our objective in going to Bayer, we sent a proposal in, and they chose three nonprofits to come and present at ASCO to their executive team in a Shark Tank-like forum. Well, I'll just say it was intimidating. And so we worked for the next 6 months. We worked tirelessly to pull together a collaborative team that could help you understand what molecular profiling was, to also help, how could we educate the community oncologists. We love these oncologists, but they are seeing a lot of different cancer patients. How can we put a spotlight on cholangiocarcinoma so they know what needs to be done when they're seeing our patients out in a community setting, not in an academic setting. Okay, so our specific goals were to increase outreach and education both to patients and community oncologists about genomic profiling and clinical trial participation in a targeted and measurable way. You may have seen this quote, right? If you want to go fast, go alone. If you want to go far, go together. So this is what we wanted, and we needed partners to help us do that. So you can see the patients are in the middle because you are our focus. You're the reason that we do these initiatives and these collaborations. And I'm going to tell you just about this collaborative opportunity. So we would bring the patients, we would provide resources, we would educate them, would facilitate the goals and objectives, convene all the parties, and track the metrics of what we wanted to do. Iron Communications offered pro bono to help us with strategic communications plan, help us with public relations and media outreach support. Komodo Health, you may have seen in our press release last year that we have a partnership with Komodo Health. They have been amazing. This has provided us with real-time, comprehensive picture of the patient landscape. We can see where the patients are being treated, what kind of treatment they're getting. It just has given us an enormous amount of data, and specifically, we can target where the patients are being seen in the United States so that we know where the education needs to go. And here's some more of the data that Komodo Health helps us to see. We can see hot spots around the U.S. where patients are being seen, but there's not a major cancer center. We can see referral patterns. We can see if those cancer centers are referring their patients into the major cancer centers. We can see, it helps us know where we need to do the education and the outreach among various other options. Okay, DMD has helped us with a very targeted email campaign to community oncologists. So we took from the Komodo data these community oncologists who were seeing a high number of cholangiocarcinoma patients, but were not involved in publications and were not involved in clinical trials. So that's where we started this outreach. And then DMD helped us by adding in their PAs, their APPs, their office management staff. We just scattered all this information so that we can get the information to you in a community setting. D2 Creative, they helped us with the media content, and I'm going to show you that in just a minute. But this is such an amazing team, and I don't know if Lauren is here. Is Lauren here? Lauren, stand up and introduce yourself. This is Lauren. Hello, Lauren. I've never met Lauren. I've talked to Lauren 1,000 times. So thank you, Lauren, for being here from D2 Creative. This has been just an amazing collaboration, and we have many of their videos. They've worked for Stand Up to Cancer, and they have put such passion into their work. I'm going to show it to you in just a minute, but have been great partners, and they've really tried to make these videos simple and digestible for you, and even for a community oncologist who's just not familiar with genomic profiling. So they're called Illuminations, and we're gonna watch one. They add a little bit of humor, a little bit of metaphor. It's the right science, but in a way that you can understand. So, and then we have Perthera. Perthera's been a great partner for us, and they are a patient concierge. They do not do the genomic profiling, the molecular profiling. They do not do that. But what they do is help facilitate that. And then when you go through them, they facilitate the testing, and then you get a very patient-friendly, it's very understandable of what that means, and then they give you a list of clinical trials that you might be interested in because of the mutations that you have. Then your community oncologist, or even if you're at a major cancer center, it gives them a provider-friendly analysis as well. So you will get both of those. This is for free. This is done for free. They're helping. They agreed to join us in a partnership for free for 1 year. Okay, so this is our team. And what we were trying to do was establish a blueprint for outreach for other small nonprofits of rare cancers who are trying to reach out and educate their patients and community providers. So outreach and education, genomic profiling, clinical trial participation, which equals more research, which is a better quality of life and longer life expectancy. So there you have the roots. Thank you, Rick, for the graphics. Okay, so a 1 year time frame was set. This was from last ASCO in June, and then we will report to them in next June. Monthly metrics, adjustments made when necessary. Okay, so I'm going to show you the video here. So can you start the video?
Molecular profiling of cholangiocarcinoma. There are more than 200 different kinds of cancer, each named after the part of the body and type of tissue in which it's found. But even among people with the same cancer, no two tumors are exactly alike. That's because the cells that make up each person's tumor have their own unique features, or mutations. And those mutations can affect how or if the tumor will respond to various treatments. Molecular profiling looks at the DNA, RNA, and proteins in the cells that make up a tumor. This testing can identify specific mutations or biomarkers that might make your tumor respond well to certain drugs. While there are few approved treatments currently available for cholangiocarcinoma, there are many known mutations associated with this cancer. Your tumor may have a mutation that is also seen in other cancers. In that case, you may qualify for a clinical trial or for a treatment that works in another cancer with the same mutation. More than half of people with cholangiocarcinoma have at least one of these targetable mutations. That's why molecular profiling is so important. Knowing which mutations you have could open the door to newer treatments for your cancer, including targeted therapies, immunotherapies, and clinical trials. Since molecular profiling can help direct your treatment, it's important to be tested soon after you're diagnosed. The tissue taken during your biopsy is often sufficient to do the profiling, but sometimes a second biopsy is required. So be sure to tell your doctor early on that you're interested in molecular profiling. With time and treatment, the biology of a tumor may change, so profiling may need to be repeated if the cancer comes back or spreads. This could reveal new targets for treatment. A message from the Cholangiocarcinoma Foundation. Learn more at mutationsmatter.org.
Lauren, do you want to stand up again? Their team did this. So. Yep. So you may have guessed that that we won. Now, what you just saw was the result of us winning. We didn't have that put together. That's been another several months to put that all together. But we won that award from Bayer. It was a $100,000 grant to do this initiative. And they were so impressed by the team we'd put together and what we were planning to do that, that they gave us an additional $25,000. So thank you to Bayer for supporting patient advocacy and these kinds of really important outreach that we're doing to help the patients. So you saw the patient version. There's also a provider version. And then we also did a tumor agnostic version, meaning that it's not cholangiocarcinoma specific. It could be for any tumor. We have collaborated widely. We're members of the GI Cancers Alliance, which is all cancers in the GI are represented in this group. And we collaborate widely. And because we're a small foundation, we have been so blessed by other nonprofits who have helped us along the way, who have given us access to documents or helped us think through problems that we're doing. And so we wanted to create something to give back. So that's what we did. We created a tumor agnostic version, and we gave that freely to all of these other, regardless of GI or anywhere, all cancers that are where genomic profiling is important, molecular profiling is important. We wanted them to have that they could share that with their patients. So we sent that letter out and have had amazing response from that. So I just want to give you a little update. These are the numbers. We've sent out 2 emails since we're at the very beginning of this, since the video was completed. So it's been, you can see that the mutationsmatter.org has been viewed almost 4,300 times, and that the users spent 2 minutes and 53 seconds on the patient page, and the providers spent 3 minutes and 10 seconds. That is amazing that the providers would take the time to watch this video and to look at the information so that they can help you. So anyway, so this is the program. So here is the thing, and we have some volunteers up front. You saw that the information that helped us get that grant from Bayer was a patient survey. So if you're a patient and you have a phone, would you please go to this? We're going to take the exact same survey. It's like 9 questions. It's very simple. Yes, no. SurveyMonkey, if you're a patient and you do not have a phone, would you raise your hand and they will bring you a paper copy? We're just going to take a minute and let you fill that out. And because these surveys really help us to know if we're doing our job, if we're spending the resources where we need to support you. I just want to again thank anyone else raised hand who needs the survey. I see one in the back. Robin. I see one over here. Okay, perfect. Just take a minute and do that, and then I'm also going to, we'll gather those up at the end, and then we'll provide the information from the survey at the end of the conference, and we'll see if we've had some improvement. Does anyone have any questions about the initiative? Yes.
A hand. There we go.
Okay. Hi. Can you tell me, is there any data between people who did not have any mutations on their first round when they were first diagnosed, and then if they had a recurrence, what's the percentage of people that actually had a mutation that was targetable on the second on the recurrence that wasn't available initially?
I'm going to let Louis and Jennifer. Either of you have any thoughts on that? Is there another mic?
Yes.
Yeah, right up here. Susan, thank you.
I've heard you might want to put the HTTPS.
Oh, yes, HTTPS:// sorry.
Well, Jennifer, I'll answer as well. I honestly don't know an answer to the question specifically. So your question is what the proportion is of individuals who are positive the first time that might be positive for a different mutation the second time as well. I don't know that we know that for sure. What we do know, and I think the early data has given us, is a pretty good idea of the proportions of people, for example, with intrahepatic cholangiocarcinoma who have a particular mutation. And then, of course, there's sort of a deeper dive to understand if they have one mutation, what proportion might also have a different mutation. Occasionally, we'll see mutations that kind of hang together. But then for some mutations, they also seem to occur independently of each other. So I'd say that'd be my best answer at this point. Jennifer.
It's a very good question, and it's one that I think we're all struggling with for multiple reasons. I think generally we haven't seen big changes because those really important driver mutations that cause the cancer in the first place, like the P53 and the KRAS and that, they don't change. But I think it's very true that mutations that move, so tumors that metastasize to different parts of the body, they become more clonal and they become different from the primary, and they do take on things that may be more vulnerable. And I know that in the early work that was done with the FGFR fusion mutations, where we know now there's a drug, they saw that patients that were initially sensitive to that drug developed a specific mutation within that fusion that then made them resistant. And then they found that another drug of the same class could then overcome. So there's the ideal situation in which you actually understand the change. It's happened in lung cancer a lot. And then you can change that. But I think, much to Stacie's point, is I think that we don't have enough information in cholangiocarcinoma. We have not been getting biopsies enough. I was listening to Stacie, and one of my problems is I meet a patient who has just had it diagnosed and has a tiny little sample from a brushing or a tiny biopsy, even though they have much more diffuse disease, and they don't want to have another biopsy. They want to get going on treatment as soon as possible. And so I think we're changing, because I think a couple of years ago we might have said, that's okay, we'll get it for you later. Whereas now, with all these possibilities and things that we can treat, we are kind of saying, let's take another week or two and let's get a good core research biopsy to get you properly profiled. And I may even ask you to do it down the road. So I think with this kind of education and promotion and providing hope that there are more targeted agents to try, we're going to get better data. But that's the big question in oncology.
Thanks. I just, I'm a physician, but I just want to also, and I'm from Toronto, and I just want to talk a little bit about what the patient experience was, and that when, my husband was diagnosed, it was because of the work and research I looked into to talk about doing profiling, and basically the oncologist was, they were okay with me doing it, but it wasn't like that they recommended it, and I had to pay for it, and thank God I had the means, where I can imagine there's a lot of patients who don't have that means, and then I had these targetable things, but it's like, no, we still have to do first-line treatment, and it was a brutal first-line treatment, so we're now at the stage of looking for what's the next step, but it's like, my experience is it's sort of like each institution has their own little clinical trials, and depending on where you're at, that's what you get exposed to. It's not necessarily easy to sort of know what the other people are doing, and how do you get access to something that may be the lucky thing that helps you. And I'm, you know, within the profession and can navigate, but I'm still having a tough time. I can't imagine what all these other patients are going through. And yeah, so I guess that's my 2 cents.
Yeah, and that's what Melinda does all day long, is help patients navigate and find appropriate clinical trials, find a second opinion if their doctor is not interested in getting them profiled and doesn't have any clinical trials available, right? I want to make it very clear that we are not promoting any clinical trial. We are promoting that you know exactly what's on the table for you, and you decide. You are in charge. You decide if you want to participate or not, but I think at least you should know what the options are. So, we have some more questions. I think I can take 2 more questions because we're a little bit behind, but I'm happy to talk with any of you after. Go ahead.
Quick and easy. On the patients that you found that did not get the genetic profiling, and it may be a takeaway, did you find that the patient wasn't aware or that the physician wasn't aware? I know you briefly touched on it, but I think with a rare disease or a rare cancer, you find that some of the clinicians even don't know beyond the patients not knowing.
Correct. The question, the way the question was phrased is did the patient know? And they responded that they did not know. So I would assume that that means, and I think sometimes, you know, your oncologist may lay out all the options for you, and you just can't even take it in. You know, of course, there's some of that, but according to the patient's responses, they had no idea. So thank you.
Also, this may be for Jennifer, or clinician. In the idea of ongoing testing, what would be a recommended best practice for getting a second or a third genomic testing? For example, many people in the room, or a lot of people, might have had testing at their surgery, but then months or a year later there was recurrence and the tumor was somewhere else. Would it be best practice to have that new MET also genomically tested? And if so, what's an adequate size for the test?
Do they have a microphone up here? Yep. Thanks, Susan.
So also a very good question. So first of all, the biopsy has to be safe and feasible, and there's sometimes when that's not possible. You need a decent amount of DNA, and if your institution has a platform that also can look at RNA and that, then you need more, right? So generally, these are not little tiny needles. These are bigger core biopsies. And some cholangiocarcinoma is very fibrotic, meaning that there isn't as much cellular material there. And so I think if you're having a research biopsy, it should be done in an interventional radiology department where they know how to get safely 3 or 4 good core biopsies. So that's question 1. When to do it is a good question. So I think that if your disease has taken a big change in its course, so surgery was when they thought you were curative, okay? And there's a good amount of sample there. But at a later point in time, you come back with metastatic disease, that would be a very good time to update the profiling. The other thing I might just add is that these next sequence generation profiles that Stacie has alluded to have evolved significantly in the last few years. So a platform from a few years ago might miss some of the fusions and things that we think are very important now. So probably when you've got really serious new news would be a reasonable time to get it redone. Of course, again, safe and what can be afforded and what can be done. Many big institutions now will have biopsy research protocols available to try to get what is called a progression biopsy, which means a biopsy when you have changed on what was previously an effective therapy. Now, I have to be honest with you, it's not an easy talk to have with patients because, one, they've had bad news that day, and two, you want to biopsy them again. But again, I think as this message gets out there that we have something to do about that biopsy, it's better. Thanks. We're going to have a whole session on that in the coming days with some experts. And I'm not an expert in liquid biopsies, but it is a rapidly evolving field. And I think what you're getting at is it's going to replace the tumor biopsy very soon. Maybe not quite yet, but it's coming.
Yeah. Great question.
And we do need to move on.
Yep, we need to move on. Thank you, everyone. And if you have a paper response, if you just get it to someone in with one of the green lanyards, one of the volunteers. Sue and Lorraine, do you want to come on up?